Everyone, I'm Rob Murphy. I'm the Executive Director of the Institute for Global Health here, and I'm the John Philip Fair Professor of Infectious Diseases and Professor of Medicine and Biomedical Engineering here at Northwestern. Thank you all for taking the time to join us today for the Institute's annual Global Health Education Day. And while we're unable to gather in person this year, we're thrilled for the opportunity to engage with our global health affiliates, partners, and community members in this virtual format. Today, our guest speaker, a keynote lecturer, is going to be introduced by the director of the Center for Global Surgery, Professor Faizan Abdullah, who's a professor of surgery in the Department of Pediatrics at the Lurie Children's Hospital and Feinberg School of Medicine. So Faizan, please take it away and introduce our distinguished guest. Thank you.
Thank you so much, Dr. Murphy. It's an incredible honor and privilege for me to introduce our keynote speaker today, Dr. Abebe Bekele. He is the Deputy Vice-Chancellor of Academic and Research Affairs and the Dean of the School of Medicine at the University of Global Health Equity in Ethiopia. Professor Bekele is UGHE's founding Dean of Health Sciences. He's a general and thoracic surgeon and a professor of surgery at Addis Ababa University School of Medicine in Ethiopia. He's also a fellow of COSEXA and the American College of Surgeons, and I've had the incredible privilege of knowing him for the last 7 or 8 years. We were just chatting and he reminded me of when we had originally met, and we just met last in 2018. He also serves as a member of the council of and the chairman of the Examinations and Credentials Committee of COSEXA, which is the accrediting and professional entity in East, Central, and Southern Africa. Professor Bekele has been bestowed many prestigious fellowships, including those from the American College of Surgeons, the University of Washington, and the Foundation for the Advancement of International Medical Education and Research. He's published more than 55 original articles, case reports, and book chapters in renowned international journals, and he's the recipient of many regional and international awards. He also has served, as if he's not done enough, he's also served as the CEO of the Tukur Mbesa Teaching and Specialized Hospital in Ethiopia and Dean of the School of Medicine of Addis Ababa University. I can personally testify that he has a vast experience in education leadership within Ethiopia and internationally. Within Ethiopia, it's at the undergraduate, postgraduate, and fellowship level. He's also been involved in simulation-based education programs and educational research. He also is actively engaged in the Global Safe Surgery and Anesthesia Initiative, which I also had the privilege of supporting the GE Foundation when it launched in 2015. And he's also served as a senior advisor to the Federal Ministry of Health in Ethiopia in the Saving Lives Through Safe Surgery flagship initiative. He's married and is a father of 3, so he's a family man. And we're so pleased and privileged to welcome you, Professor Bekele. Just so everybody knows, there will be some time afterwards, after his presentation, to submit questions. So please use the chat feature. I'll keep a lookout. You can do that real time, and then as soon as Professor Bekele is finished, I'll read out some of the questions, and we'd be happy to have some discussion around that. Without further ado, over to you, Professor Bekele.
Thank you very much, Professor Faizan, for this very generous introduction. Let me first start by thanking Dr. Ashti for the very kind invitation to join you today. I'm very privileged to join you. Northwestern is a huge partner to us at UGHE in Rwanda. So it's really a privilege for me to join you here. Today, I'll try to talk about managing medical education and COVID, the UGHE approach. And in so doing, I'll try to introduce my university, UGHE, to you, and also introduce the College of Surgeons of Eastern and Southern Africa as much as I can. I'm a surgeon by profession, so please forgive me if my presentation is skewed a bit towards surgery. At the moment, I serve as the Dean and Deputy Vice-Chancellor of Academic Research Affairs at UGHE in Rwanda, and I still have a faculty position in Ethiopia. I have no relevant financial relationships to disclose. So let me start first by talking about who we are at UGHE. UGHE is a new university formed in Rwanda about 7 years ago, with a very grand vision of building the next generation of health professionals, doctors, nurses, pharmacists, public health professionals, into leaders and change makers. It's a real big vision, hopefully in partnership with you, all our partners around the globe. We hope to achieve this in this part of the world. UGHE is owned by Partners in Health. Partners in Health is an NGO housed in Boston. And PIH entered Rwanda in 2003 upon the invitation of the Ministry of Health in Rwanda. Within 10 years, PIH managed to help the government build 3 hospitals in Rinkwavu, Kirehe, and the last one in district called Butaro. The establishment of the Butaro hospital was the ingredient that was needed for PIH to think about academics. And the first global health delivery course in partnership with Harvard Medical School was conducted in Kigali in 2012, right after the hospital was built. This showed that the world, the continent, is ready not only for healthcare, but to equitable access to education. And in 2015, with the help of donors such as Bill and Melinda Gates Foundation and the Cummings Foundation, the UGHE was officially established. The first unit we set up was called our Institute of Global Health, and the Institute of Global Health started the Masters in Global Health Delivery program in 2015. In 2016, we opened our Center for Executive Education, and the first batch of our MGHD students graduated in 2017. In 2019, we opened our School of Medicine. The School of Medicine in the rest of the world, it's called MD program, but in Rwanda, it's called the MBBS program. I'll say a few words about that later. And we inaugurated our campus at the beginning of 2019 in January. Again, in 2019, the MGHD program was divided into health delivery and One Health track. We set up our Center of One Health, and we set up our Center of Nursing Midwifery. Then came our Institute of Global Health Equity Research. Then we launched our Nursing Leadership Program this year, our Gender Equity and Sexual Reproductive Health Master's Degree Program, and our Center of Global Surgery. Hopefully, we will start our MGHD concentration in global surgery very soon. To say a few words about our MGHD program, at the moment we have 3 tracks in it, in health management, One Health, and SRH. And hopefully next year, a master's degree in health service administration and global surgery will take place. At the moment, we have graduated 5 cohorts of students. The 6th cohort is being trained. And so far, we have recruited students from 18 countries. The 7th cohort, the recruitment of which we just concluded a few days ago, are going to be from 21 countries. The second center we have is called our Center of One Health. As you probably know, One Health is an interplay between human health, animal health, and environmental health. UGH is a strong believer in the One Health approach to health. And we have started our master's degree program in One Health last year. The first cohort of 8 students will be graduating this year. The third center we have is our Center of Executive Education, where we do customized short course training for global health professionals in 3 different formats: a 9-month, a 6-month, or a one-time program. This has become quite an Our School of Medicine houses our MD program. It's an innovative type of degree program in Africa. The MD program in Rwanda is called MBBS. What makes our program different is that Our MD program is integrated with the MGHD program. It's a dual degree program, 6.5 years. It's like the MD and PhD program we have in the rest of the world. And by policy, we have decided to recruit 70% female students, cognizant of the fact that females are underrepresented in the profession. The Butaro District Hospital is our teaching hospital. Again, this is a hospital built by PIH. And our third cohort, which includes about 21 international students from the continent, hopefully will be joining us in January. The following are what makes our program a little unique. We strongly believe in competency-based and integrated curriculum. Basic science and clinical teaching are integrated. Almost all our students spend at least 5 months across the 6 years of training in the community in our community-based education program. We have introduced innovative pedagogy to teaching. 70% of what we teach is through flipped classes, team-based learning, and case-based or problem-based learning. We have integrated simulation and lab-based teaching in our basic science and clinical education. We're trying to
We may have, oh. Professor Bekele, we've lost your audio now. I think your video is moving. If you want to unmute for a second, it looks like you're muted.
Can you all hear me?
Yes, we can. Go ahead.
One of the things we in this part of the we navigate through is such an internet connection. So please bear with me. My apologies. So as I said, 90% of what medical doctors are expected to do in Africa is emergency and emergency-based care. This is what studies have shown. So we have decided to train our students mainly in emergency-based care and focused on surgical procedures. These include cesarean sections, appendectomies, and close manipulation of fracture. UGHE does not charge tuition fee, mainly for undergraduate students. We hope to provide quality education. But if you put dollar figures to tuition, that means we are selectively selecting those who can only pay. That is against our principle. So I'll talk about it a little bit later. Our students will have early exposure to research, leadership, and management. The faculty will go through continuous faculty development programs in partnership with our partners, and teaching will happen at a district level. And as I said, the One Health approach to healthcare and continuous monitoring and evaluation, again, are pillars of what we do. At UGHE, we set up a program called Umusanzu. Umusanzu literally means contribution in Rwanda. That is, instead of asking trainees to pay directly for tuition, we ask them to pay it forward. So they sign contracts with their ministries of health and commit to serve 6 years after graduation in exchange for what we provide. That includes tuition, board, academic resources, and transportation. So ability to pay is not one way of selecting our trainees. The fourth program we have is our Department of Community and Social Medicine, where we have a community-based education, community-based participatory research, and community service components integrated to it. Hopefully next year, we will start a program called CBE Global. This is a program where foreign medical students and foreign students from across the world can join us officially and spend 1 month in the community and getting the real taste, the real sense of what global surgery, global health experience looks like. The curriculum is almost completed, and because of COVID, it was postponed by 1 year, but hopefully will be launched next year. Our Center of Gender Equity is in charge of our MGHD track in SRH Master's Program, is responsible to conduct the Gender Equity and Social Justice Program for our medical students, and has already set up a good mentorship and research program. Our nursing and midwifery unit at the moment is conducting an executive education program in nursing and midwifery, and hopefully 3 master's programs will be launched next year in leadership and medical and oncology nursing. These are being developed. And the last would be our Educational Development and Quality Center, which would be the central department unit at UGHE, mainly responsible for faculty development, student assessment, program evaluation, introduction of innovative teaching, educational research, and hopefully we'll launch a master's degree program in health professions education soon. This will be our quality assurance unit moving forward. Our campus is found 2.5 hours drive away from Kigali, as you can see in the middle of a beautiful nowhere. It's in the middle of the jungle in the real community, surrounded by just a few houses and a deep rural community. And this is what it looks like. Now, COVID has not been kind to the African continent. It really hit it hard. And unfortunately, the 3rd or the 4th cycle, we're not sure, is ravaging through it at the moment. And it's at the moment, Rwanda is one of the countries that did a fantastic job in controlling it. There are less than 30,000 cases, less than 400 deaths reported, and about 500,000 people, about 400,000 are already vaccinated. The community spread is really put under control, and at the moment the trend is towards decline. But this is not true for the rest of Africa. The consequence of COVID in the continent has been really bad. Almost all undergraduate medical schools have been shut down for 1 year. So medical students have lost 1 year of their time. Residencies and fellowships were reduced by at least 75%. Those institutions that were able to do online teaching survived a bit, but the majority really suffered. And across the COSEXA region, there is a registered statistically significant decrease in the number of operative cases and experiences. The consequence has been almost all the graduates were unable to meet the case number target, which obviously has an impact in their surgical learning curve. And there were serious concerns about operative anatomy by their trainers. Almost half of our surgical trainees across the continent were deployed to COVID care, and more than 3/4 lost significant exposure to OPD, outpatient care and training. Across the world, surgical colleges have cancelled, postponed, or adjusted their exams. The college that we belong to, COSEXA, is no different. It really received a huge hit from COVID. And 90% of our trainees reported impact in their mental and social well-being in the form of interpersonal relationships, marriage, academic life, and a social life. Almost all of them reported disruption in their social life. However, COVID was not all bad. There's always a silver lining. UGHE is probably the only medical school in the region that did not shut down. We successfully managed to shift to online teaching, both synchronous and asynchronous. And the graduation was conducted virtually on the 9th of August last year. We did not shut down the campus totally, but we managed to change it to an island. The geographic location of the campus helped us a lot in isolating the faculty and the students there. And so far, we haven't yet registered a single case of COVID so far. all lectures were converted to online. These are the young medical schools doing their biochemistry lecture. We tried to do a bit of virtual simulation, a bit of virtual laboratory, and our anatomy teaching shifted to what we call anatomage table, and a degree of success was recorded there. However, our cadaveric-based teaching, our in-person simulation and laboratory teaching, the entire community-based education, and data collection in the community, mainly practicum, was completely interrupted. Now, some of the things that enabled us to keep our school open, the university open during those difficult times, were the following. Rwanda had a very good, reliable internet connection, different from other African countries. This helped us a lot. And as a policy, we tended to distribute laptops and tablets to our faculty and students. We had Canvas as our LMS, and we had existing partnerships. These really helped us in navigating through those difficult times. The e-learning unit we set up 2 years ago was able to adapt to this change, and the resilience of the faculty and students to be open enough to get trained on how to do online teaching, how to record online videos, and their willingness to keep on learning, learn from mistakes, learn from experience, and keep on adapting was really instrumental in what we did. Students and faculty continuously went through faculty development programs. Together with our partners, we set up various e-learning training programs, which really helped us catch up with what was happening because of COVID. The leadership also learned its lesson. Resources were made available to adopt to the changes. Our partners, I was able to attend to the presentation you had a few hours ago, the last 10 minutes of the presentation, and you talked about partnerships, which I think was really instrumental in helping us stay afloat. We had lots and lots of visiting, Zooming faculty from the US that helped us conduct online sessions, flipped class resources, team-based learning resources, clinical cases. Partners shared with us their available applications and softwares, and our LMS was built well enough together with us and our partners who were ready to help us. These are some of the partners that really helped us navigate through the COVID time. And basic sciences teaching through e-learning wouldn't have been possible without such resources. Recorded videos, assessments, flipped classroom resources, and others. Student assessment was a bit difficult during the COVID period. We used our LMS to administer written exams, the MCQs. And as you can imagine, keeping the safety of MCQ exams online has been a bit of an issue, but we responded by using the lockdown browser that helped us keep the security. And we were able to conduct end module exams through Zoom, case-based oral exams through Zoom. Without quality assurance, we probably would have run into some problems, but we managed to do continuous mid-module and end module course evaluations by the students and by the faculty. Faculty were also given the opportunity to give us feedback during academic commission meetings, council meetings, and one-on-one meetings with the leadership. We made sure pre-class tasks and post-class homeworks were adhered to, and attendance was strictly taken during teaching, and virtual office hours and virtual town hall meetings were arranged with students and faculty. COVID also opened opportunity for our students to engage remotely. We created 2 programs known as Big Brother, Big Sister program. This is a way of partnering our young students with medical students in the US. This helped them discuss, talk, share resources, and mentor each other. And with the University of Virginia, we developed a program called eGlobal. eGlobal basically is a program where we twin two of our students with two students from University of Virginia. And we created a team of 4. These 4 students selected a research project to work on 1 year online. And we're very happy to see that almost all of them completed their projects a few weeks ago. Their output is being published recently. And this probably would be the very first research publication for our medical students. These are 18, 19 years old boys and girls who had their first ever experience in research in such a global partnership manner. Moving forward, what COVID has shown us is that we need to adopt, we need to learn, we need to expect disasters, we need to learn from what happened last year. And we learned that the leadership should be able to understand what's happening today and not get stuck on the past. The leadership should be able to predict what's going to happen tomorrow and should be willing to change. By change, we mean allocate resources, allocate the human resources, money, and the monitoring and evaluation tools. And partnerships are really key to the way forward. The resources are usually out there. Our experience has been resources are usually out there. It's a question of creating the partnerships, South-South and North-South, and working with governments is also important. The communication between leadership, students, and faculty is key. Leadership should be able to listen to its faculty and students, and ability to develop a flexible academic calendar saved UGHE from completely shutting down. In other words, resilience of the entire university, students, faculty, leadership, the entire university helped us a lot. So in conclusion, UGHE is a young university in Rwanda. It's not a Rwandan university, it's a global university in Rwanda with one campus in the rural part of Rwanda, and hopefully with partners, working closely in partnership with our partners, the plan is to, in the near future, be a real global health university. Again, thank you very much for inviting me to join you today. And if there are any questions, I'll be very happy to address them. Thank you very much.
Thank you so much, Professor Bekele, for a really amazing presentation. And I found it fascinating as you shared the journey of, the origins of, the institutional affiliations and the partnerships. And so it really was amazing to hear the journey, of the development of the university. I think what was also fascinating is, you gave us a tremendous overview of the different educational programs, of course, extending from the MBBS program to the master's programs to the graduate side of or the graduate medical education side of it as well. I found it really quite fascinating. I already have 1 or 2 questions in the chat box, which I'm going to read in a moment, but I've got a burning question as a fellow surgeon myself. One of the things I found most interesting, I'll take the liberty of asking you first, if that's okay, and then we'll get to some of these questions. I found most interesting was that you mentioned that unfortunately across COSEXA, which is of course the college, the professional surgical college, for those who may not be familiar, of East and Southern and Central Africa, you mentioned that statistically that cases are down. And what's fascinating about the part of the COVID story you told is that there's no question that COVID has wreaked havoc to our entire society globally and locally there. And you mentioned that medical schools were shut down, et cetera. But I was curious, on some level, you might expect that surgical cases, because of COVID, despite COVID, surgery is a contact sport. We've got to get in there and do the operations. And our trainees, on some level, you'd say, well, those cases, despite COVID, would still be available. But you could also understand a scenario where, because of COVID, we, at least here at Northwestern and at Lurie, we at sort of the peaks of the pandemic did limit exposure of our trainees to surgical care because we wanted to limit exposure to potentially COVID. So I was curious, would you say that surgical training was impacted to the same level that, the medical schools were shut down, or was it somewhat resistant because of sort of the actual contact nature of surgical care?
Thank you, Professor Vizen. Yeah, you're right. The surgical education in the Costexa region was hit hard for a couple of reasons. Number one, as you know, the trained medical professionals in Rwanda in Africa are not that huge. So when COVID came to the continent, there was continental panic, and almost all professionals were repurposed to COVID care. Surgeons became intensivists, residents became doctors in COVID wards. There was an immense shortage of PPEs, gloves, and alcohol was saved for quote-unquote COVID reserve. And most countries went into lockdown. In Africa, lockdown means you are really locked down. It would be unwise to assume that doctors and nurses have cars in Africa. So when there is lockdown, you can't even access public transport. So doctors and nurses are locked at home. The same thing with patients. So patients are locked at home with their surgical needs. They don't have access to surgical care. Most people are not working because of lockdown. They don't have money to come to healthcare services. And there was immense fear among the population, the doctors included. Population were afraid they would contract COVID if they come to the hospitals, and they opted to stay away. There is publication out there that if you look at elective procedures, 90% of elective procedures in the US are elective procedures. The number goes down to 75% in Europe, but they are less than 50% in Africa. So it turned out later that locking down, shutting down emergency procedures did not actually affect surgical volume, because the majority of procedures being done in Africa were emergency. Unfortunately, emergency patients were not even showing up because of the various reasons we mentioned. It's only after 5-6 months that countries realized that they should approach this in a different way and started ramping up the surgical care. But it was too late. Ventilators were repurposed to COVID care. ICU was repurposed to COVID care. The doctors were not there. And quite a number of professionals contracted the disease and in fact died. So because of all these various reasons, numbers went down, mainly emergency and then elective.
Wonderful. Thank you so much for sharing that perspective. I'm going to get to some of the questions here. First, of course, a congratulatory comment from Dr. Leonard saying thank you. That was wonderful. Next, Lisa Hirschhorn says, Dr. Bekele, many thanks for the wonderful presentation and lessons learned. How can these lessons and knowledge be transferred and applied to other universities to make them more resilient for current and future health or social shocks? Could this be used, for example, in an area which is fragile or conflict affected?
Thank you, Dr. Lisa. I think that is right. What COVID has shown us that we were not prepared. As a continent, we were not prepared. What's going to happen for COVID-21 over COVID-22? We need to understand the fact that we are living in a continent where health services are very fragile, academic programs are very fragile, and get prepared for it. One of the lessons we learned is we need to be prepared. We need to make sure we have appropriate e-learning facilities and resources. We need to develop the partnerships that are already there. Earlier, I heard discussions about decolonizing global health. One of the ways of decolonizing global health is believe in equitable partnerships. And the partnerships are out there. They are out there. We are witnesses to say to the world that such partnerships are out there. And using available resources, using the available human resource that's willing to help us is one way of tackling the next epidemic. And the resilience of students, resilience of faculty, resilience of leadership plays a key role in this. Getting stuck in saying, you know, this is how we used to do things. We wait until the epidemic goes away and we go back to where we were. Probably will not work. So getting prepared for the worst now, when things are kind of okay, is probably the right thing to do.
Thank you so much again for that incredible insight. I'm going to share another congratulatory note from one of our institute directors and our prior sessions moderator, Dr. Dubai Prasad, who said, congratulations on all these successes during such a challenging time. We would love to support co-learning with your medical students and residents. And then I'll move on to another congratulatory comment and question from Samuel Randall. Wonderful presentation. I'm excited to see that the university placed an early emphasis on One Health. And as we heard from the dean, that One Health is, of course, human, animal, and environmental health in terms of the intersection of that program. And the question is, how do you see this approach playing a greater role in medical education for all students, as well as our global health efforts in a post-COVID medical context?
Thank you. Well, there is no evidence ever to show the One Health approach is the right approach than COVID. COVID is a result of the interplay of these three determinants of health: humans, animals, and the environment. Unless we learn now, when are we going to learn? So unless our students are prepared to understand that we cannot talk about health without addressing human health, animal health, and environmental health, then they are not going to be ready for what's waiting for them in 5 years' time, in 10 years' time. So I think the trick is going to be to define COVID as a One Health disease, as a One Health disaster, and embed the One Health approach in every discussion we are doing with our medical students. The disease pattern we see in Africa is a true expression of the One Health approach of diseases. You name every infectious disease, most cancers, most emergencies, these can easily be approached through human health, environmental, and human health. So this pandemic has shown us that the One Health approach is the right way, and that's why One Health is an integral part of what we teach here at UGHE, and we have a standalone center for One Health.
Wonderful. Thank you so much for sharing that perspective. And I'm going to ask forgiveness of all the participants. You can't have two surgeons be the moderator and the presenter and not keep talking about surgery. So we're going to ask another question. I'm going to take the liberty and ask another question about surgery. I think the fascinating thing you mentioned was that 90% of the cases that you're facing, did I hear you right? 90% are emergencies.
Yeah.
And I think there's two dimensions to this. One is really, and I think we were talking before the session started too, I'm just still so fascinated by the fact that all of our graduate medical education trainings and programs, particularly in high-income countries, they really don't really fill the needs for sort of the global health and even broader societal context in high-income countries. An example we were talking about was the fact that as a board-certified general surgeon in the United States, you're not qualified to do a C-section. I mean, how could you not be qualified to do a C-section as a surgeon, in my mind? And that's been one of the glaring things is my career between the intersection of general surgery and global health. But I was so fascinated, you mentioned that your curriculum, particular MBBS curriculum especially, is competency based. I mean, that's so cutting edge that you've incorporated simulation, it's competency based. It's only in the last 5 years that we at the American Board of Surgery have really now shifted and migrated, both in terms of our certification of trainees and also with our on the program accreditation side with the ACGME, that we're now doing like entrustable professional activities, where it used to be that, you know what, everything in the operating room, that was on a case list, and that used to get turned in even 30 years ago. But now we are now, and this happens in many other disciplines, not just in surgery, where we actually have, the trainees have to have lists of, you know what, I put in this many nasogastric tubes, this many Foley catheters, and we've termed that entrustable professional activities. And so it sounded like you covered that as part of your competency-based education. So I was curious to hear, how about the minor procedures? How do students and trainees get signed off on those minor procedures?
Yeah, thank you, Dr. Fizan. Yeah, that's a very important point. 90% of what general practitioners face in Africa is emergency. Across the disciplines, take surgery, it's appendicitis, it's trauma, it's fall down accidents. Take internal medicine, it's TB, pneumonia, malaria. Take pediatrics, diarrheal diseases, infectious diseases, OBGYN, its delivery and its complications, uterine bleeding. So it's probably pragmatic to accept this, accept the reality, and train the medical doctors to be comfortable in handling these cases. Unfortunately, our trainings over the past many years has not addressed that. And there are institutions in Africa who are actually taking this as the right approach, that we need to make sure our trainees are well versed in emergencies. And emergencies directly relate to surgery and procedures. More than 50% of cesarean sections in Rwanda are done by general practitioners who are trained on the job. So wouldn't it make sense to accept this fact and train them earlier while they're in the medical school? Appendectomies, fracture management are done by general practitioners in Africa. So wouldn't it make sense to train them while they are in medical school, when we are around to teach them, to mentor them? So that is the philosophy we had. And this is where our partners come in. The model we adopted at UGHE is to find institutional partners. Let me give you an example for surgery, for example. For surgery, we have forged a partnership with the Program for Global Surgery and Social Change, Brigham and Harvard Medical School. A team is formed here in Rwanda at UGHE, a local team to work with the team in Boston. And we team up from the inception to the execution of the program. We are developing the curriculum together. We are developing the competencies, the milestones, the EPS, the assessment tools, and planning is being done on how to teach the students. Who is coming here, when, who's joining us online, when, and planning is done together in a real equitable partnership. We're not trying to copy what's out there in the US. For internal medicine, we are working with the California University of Science and Medicine. And hopefully with Northwestern, the partnership will evolve towards the clinical disciplines such as OBGYN, pediatrics, ENT, ophthalmology. A real partnership that we will develop, hopefully our African colleagues can learn from, can adopt from. So this is how we're trying to approach it.
No, thank you so much. And we were also speaking that it's interesting when you think about the difference between the US curriculums in surgery and COSEXA's curriculum, for example. We've looked at that in the past, and as we were commenting earlier, there's really not much of a difference. I've always joked, I said, it's kind of the way people look at religion. Instead of focusing on 99% of the commonalities, people tend to focus on 1% of the differences, and that's exactly what was happening as sort of the notion of surgical curricula here and in our sub-Saharan Africa's colleagues is going to be completely different because of, typhoid perforation or the infectious surgical diseases, but that's really not true. 99.9% of it is all the same. We've got another question. It says from Dr. Horshorn saying, if I may ask one more question, reflecting on the emergency burden, how do you also train students in understanding how to deliver primary care, how to provide continually comprehensive, coordinated, and people-centered, especially training them during COVID?
Dr. Lisa, I think that's a difficult question. What we have learned, experienced last year was that COVID really disrupted our community-based education program, our clinical exposures, our dissection-based programs. So that is where the continent in general is lagging behind. There is intense work around simulation-based teaching, around other replacement kind of clinical training in this era. But unfortunately, that's where we struggled a lot. But now that most of the hospital professionals are vaccinated, the students are vaccinated, and faculty are vaccinated, things will probably normalize. So hopefully, approach to primary care, working in health centers, health posts, and hospitals will resume soon. Again, it's one of the traumas of COVID that the continent really suffered from.
Wonderful. Well, thank you so much for sharing so many amazing perspectives. And I think it's been a really stimulating discussion. And I know that I think we're supposed to wrap up within 5 minutes. I don't know if we need to take a break or not. Any final questions or thoughts? So there's a last opportunity if you want to put it in the chat box. But otherwise, again, Professor Bekele, it was so great to spend some time with you and see you virtually, albeit virtually. Next time, hopefully we would host you in person. And this way we can, break some bread together as well, hopefully at some point. So we'll give you a standing rain check. You can take that in the future. But again, such a wonderful talk and such a great discussion. And I know I certainly benefited from it. So thank you so much.
Professor Fizan, thank you very much for the invitation. I really enjoyed my presence with you today. Thank you very much and hope to see all of you face to face very soon. Thank you very much.
Wonderful. Thank you so much.
Thank you. Thank you.
So,
Dr. Bekele,
yes, go ahead.
yeah, so why don't we I can bring us to a close. Dr. Abdullah, thank you for moderating. Dr. Bekele, thank you so much for what was truly an inspirational talk. I mean, we look forward to the future when you can join us in person.
Thank you.
Leonard, I'm co-director of the Center for Global Health Education with ASHTI, and I want to thank all of you for participating and being here today for our inaugural Global Health Education Day. I think it was really a tremendous success. I would like to particularly thank our two speakers, Dr. Camp and Dr. Bekele, for providing us with really inspirational, important, and thoughtful perspectives on where we've been and where we need to go in advancing ethical and responsible global health education and training in the future. I'd also like to thank all of our poster presenters for what was really an impressive set of scientific presentations, really helpful and thoughtful discussion that they generated. I also want to thank our moderators and evaluators for the poster sessions. The evaluators, we are still sort of working on the awardees, and we'll be announcing the awardees on our website here in the future. Before we wrap up entirely, I would also like to share some additional acknowledgements from our center for this year. In our inaugural year as a center, I'd like to specifically congratulate our first two awardees of our outstanding Global Health Educator Award from the Feinberg campus, Dr. Colleen Fant, Assistant Director in the Center for Global Health Education. Colleen has done a tremendous job in terms of helping our center get off the ground. Her work in mentoring and guiding trainees and students was on full display in our poster sessions earlier today. So congratulations to Colleen. Our Evanston campus awardee is Dr. Peter Locke, who is Professor of Instruction in our Global Health Studies program. Peter is also our Director of Undergraduate Studies for the program of over 300 global health majors and minors. So it's very pleased to recognize the contributions of both Colleen and Peter to global health education across both the Chicago and the Evanston campus. Additional congratulations to our 2021 graduates of the McCaw Global Health Clinical Scholars Training Program: Tenny Brown, Susan Folsom, Roxana Garcia, Ryan Lee, George Malik, Chris Miller, Allison Murray, Samuel Randall, Jordan Sharlin, An Trong, and Caitlin Bizik. So please, a big round of applause and congratulations to all of the 2021 graduates of the Clinical Scholars Program. Lastly, as we move ahead, I'd also like to sort of talk about events and continued, hopefully, engagement of all of you in the things that we are doing as part of the Center for Global Health Education. I'd like to encourage all of you to consider participating in our monthly community of practice. This is a forum for discussing a variety of topics surrounding ethical global health education. Some of the topics that we've dealt with previously over the last year include lessons learned from our COVID practice, wellness in global health and healthcare, trauma-informed education and administration, and exploring the our life histories as learners. That is, what we all bring to the table and how that informs our training and our learning. Our next practice meeting will be later this month on June the 15th at 3 p.m. And so any of you who are interested in being part of our community of practice, please reach out to Sara Caudillo at the address and sign up to participate. Lastly, I also encourage all of you to send us nominations for this year's Outstanding Educator and Mentor in Global Health Awards. We will be accepting nominations through August the 9th. Nominations can be accepted via email at our Global Health Ed address outlined in this. So with that, I would like to close for today. I thank you all for being part of today's proceedings. And I'd like to particularly thank Sara Caudillo and Kristen Weber for their support and Herculean efforts in pulling all of this together. So thank you all very much.
for making this day wonderful. And feel free to email us or ask us any questions. We're available.